Much for this. It's hard to follow Ari with his beautiful talk, but is the choice clear? And I think we can have a really good discussion afterwards because I don't know that we have definitive data, but I think like we are almost there. These are my disclosures. So first of all, I want to just reiterate that women are not small men. And I'm just showing you, even though we have a small annulus, there is a lot of pathobiology that's very different in aortic valve disease for women compared to men. Women have less severe calcification, higher fibrosis score. They have a smaller annulus and a lower coronary height, and their hypertrophy is more of a concentric one compared to men who have more eccentric hypertrophy. So it's really important to think about, we put everyone in the same bucket, and we don't make devices in pink and blue boxes, you know, for men and women. But I'm wondering if we should, and that's something we will kind of continue to imagine. So I'll bring that up first and foremost. And it's also really important to note that when you compare men to women, and I don't think we should be comparing them, in observational studies, what the expected rate is and what they observe, women have higher mortality. And let me tell you, it's hard to believe because everyone was so excited when we saw aortic stenosis for the first time, those high-risk TAVR patients, that there was almost 50% women in those trials. And I'm telling you that women are undertreated. That 50% in the high-risk patient population is an underestimation of those women who probably had severe aortic stenosis and never were evaluated. This is a UK nationwide registry showing that even though they have a higher age standard mortality, they're less likely to receive aortic valve replacement. This cannot be. The waiting time for TAVR is longer for women. This is from an Australian center, and you see that they have a longer waiting time, 156 days for women, 147 days for men. And it shouldn't be that way, maybe because women ask more questions, maybe because they're more complicated, maybe it's harder to get a consent, but I don't think it's about that. I think it's more about just waiting and delaying and questioning whether or not this is really aortic stenosis or not, and I don't know why. The incidence is similar, actually, but if you go to the higher risk patients, most of those are women. And certainly in the smaller annulus, most of them are women. So why are they? Well, here's some of the sex-related differences in the risk profile, and this is a collaboration we did with our colleagues in the Netherlands, and we published this. Very important to note that women will have a higher prevalence of hypertension and chronic kidney disease, a lower prevalence of CAD and those traditional risk factors. That's what we saw. And if you look at the meta-analysis of women from 4 randomized clinical trials, SAVR versus TAVR, sorry, Dr. Pattakos, they do better with TAVR. They do better with TAVR. And these anatomical challenges are very, very important, especially with the small annulus and the left ventricular outflow tract, but not aortic dimensions. So again, another thing to think about. So what is a small annulus? This is an annulus area less than or equal to 430 millimeters squared. It's about 30 to 40% of TAVR patients. And that's by CT measurement. It's more common in Asians, and definitely very common in women. 90%, up to 90% of small annulus patients are women. Higher increased risk of aortic valve gradients after TAVR with a higher incidence of patient prosthesis mismatch. Well, who cares about that, right? Well, I care about it. Because patient prosthesis mismatch, which is a mismatch between the valve hemodynamic and what the patient's requirements for their cardiac output is is highly prevalent after TAVR, and a small annulus and the female sex are associated as the strongest risk factors. This is important. And you might say, well, who cares about hemodynamics? Well, the transaortic, this is exactly how we follow our patients. And we've heard it over and over again. The way you diagnose aortic stenosis, for the most part, is through echo hemodynamics, gradients. That's how we define it. And yes, there's low gradient, but that is how we watch patients. And we see that these small annuli are associated with much higher transaortic gradients, especially after TAVR. Now, I know that the TAVR field has improved our surgeons in not putting in small valves. They now are really, they're not just using the echo and putting the valve in, and it is a much, much more detailed way of evaluating patients. And we should be thanking Crébier and everyone who brought in TAVR, because the surgeons are so much better since TAVR has come. But the truth is that we still see surgeons who are undersizing their valves. We see that. And these hemodynamic impacts, and this is it's very, very important, look at it by annular size. So much more in a smaller annulus, even medium valves. And when you look at PPM risk after SAVR versus TAVR, the incidence is much more common in TAVR, most likely because the valve sizes that they put in are smaller. But this is what you are seeing. And why is it important? Does it matter? Because it is associated with more mortality. I'll show that to you sooner. This is the French TAVI registry, about 1,200 patients with a small annulus. PPM was more common with balloon expandable valves compared to the self-expanding valves. So it's supraannular. Imagine the core valve is a supraannular valve. So therefore, the valve is getting placed a little bit higher than right into inside the annulus. So therefore, you're getting a larger and better hemodynamics. Why do we care about this? Well, here's some very, very important, most common causes of aortic structural valve deterioration, which impacts on TAVR durability, has to do with these transaortic gradients and PPM. This is a pooled analysis, 1,400 patients, and it's very important to see the incidence of structural valve degeneration in small annulus. This is core valve, US pivotal, and SIR-TAVI cohort. Structural valve deterioration was associated with higher rates of mortality, cardiovascular mortality, and of course, heart failure hospitalizations. Now, again, none of this is definitive, it's associations. So we need a large trial to actually prove any of this. And the mortality impact, the impact of PPM on mortality, does it vary by sex? Now take a look. Look at the PPM in women and how that is really in partner having a major impact in partner 3. In women, they're all small annuli, guys, 90% or so, have a much higher impact on mortality down the line. Association, not causation. We do not have proof yet. But boy, isn't this a great question? And whenever there's a question, you must answer it with a definitive trial. And you have to be smart how you make a trial like this, and you call it the SMART trial. Self-expanding versus balloon expandable TAVR in all patients, not just women, all patients with a small aortic annulus. Well, by doing this, we enrolled 87% women, highest level of ever enrollment in a clinical trial in a TAVR of women. You look for a condition that is more prevalent in women, and you will get women. We're not hiding. We will come into the clinical trial. So there it is, the SMART trial. Prospective randomized, small aortic stenosis, symptomatic severe aortic stenosis, small annulus, and equipoise. What does that mean? That the operator said, I can put in a balloon expandable or a self-expanding valve, equipoise. Not in the patient that should not get a balloon expandable valve because they have a nodule of calcium sitting there and they could have rupture, and not for that patient whose anatomy would preclude an issue with coronary access, for equipoise. We randomized 716 patients and stratified this randomization by sex and site. Two co-primary endpoints. The first one, very important to make sure at 1 year, we're not going to see a difference in their hard endpoint of cardiovascular mortality, overall mortality, disabling stroke, or heart failure hospitalization. Non-inferiority. But for sure, based on everything we have known, there absolutely needs to be superiority in bioprosthetic valve dysfunction. And what is that? It's when your aortic valve area is less than or equal to 1, when the gradient is when the gradient is greater than 40 millimeters, velocity is more than 4, and that very, very importantly, you're seeing these patients, and of course the bioprosthetic valve dysfunction, we used a combination of the Capodanno and the VARC-3 definition for this bioprosthetic valve dysfunction. What was the components? The mean gradient greater than 20, moderate, with the VARC PPM criteria of moderate to greater than total AR, valve thrombosis by VARC-2 because VARC-3 definition was not yet available for valve thrombosis, endocarditis, Duke criteria, aortic valve reintervention. Almost 90% women are so proud of this. And when you get all these women, you get a lot of comorbidities. Take a look. Their age is high, 80 years old. These are frail old women. 30% diabetics. Lots of COPD. Cerebral vascular disease, 12%. Prior PCI, about 20%. And you see the history of bundle branch block and pretty much a very well done randomization. And the bicuspid valves were also in there in these old people with small annulus, about 4% rate. And here's the co-primary endpoint. The very first one met the non-inferiority endpoint with clearly within the first year. And you see through the first year, all-cause mortality similar, disabling stroke similar, as was the rehospitalization. So it met the non-inferiority, met the margin, and we met that first one. Now we go to the second co-primary endpoint, bioprosthetic valve dysfunction, significantly lower for the self-expanding evolute valve. Most of it, if not all, driven by non-structural and structural valve dysfunction, which you see here. And that is literally mean gradient greater than 20 or severe PPM by VARC-3 or greater than or equal to moderate total AR. So that is what drove that. Now, which valve would you want to have when you have a small annulus? The one that gives you the same hemodynamics, the better hemodynamic with a similar outcome when all things being equal? I would say you want the one that is better hemodynamics. Because also there was quality of life issues that came through for these patients. And you see over here for all of them, there was every consistency But very, very important is the Doppler velocity index, the severe PPM by VARC-3. Take a look at the difference. And the total AR, mild to moderate AR, just meeting the significance. So, ladies and gentlemen, small annulus is pretty prevalent, especially in women. We're very different than men. There is definite association of the small annulus with post-AVR gradients and PPM. It could have an important outcome in long term. Much more common PPM in SAVR compared to TAVR. But SMART is the largest trial to randomize patients into 2 widely used TAVR and the largest ever TAVR trial to enroll mostly women. And we found that there was non-inferiority in the clinical outcomes, but certainly a superior valve hemodynamics. The 5-year data will be very much telling. Does PPM and these valve hemodynamics matter? Will they make an important impact on these other things like valve thrombosis and worsening valve dysfunction down the line that has an important implication? Time will only tell us. Thank you for your attention.
Thank you, Dr. Mehran, for a very inspired and informative lecture. We open for discussion. We have 2 panelists, Dr. Perreas.
Yes, thank you very much. This was very clarifying. I'm a surgeon, so I was very impressed. And this is...
Sorry. But, you know, you guys should do valve, you know, you should do enlargement surgeries.
Yes, well,
aortic enlargement.
You know, I'm really grateful because what I see is that in the US, there's a great discussion that Professor Finkelstein started. A lot of surgeons are involved, so that's why we're here too. We have a very close collaborations. We think the end result, just to get this previous discussion from the very beginning, we can forget about being very clear and preferential in patient choice if both parts of the team are involved. So if you have a surgeon and a cardiologist who have no infested gains in this situation, then you know the decision is going to be a clear decision for the patient. Going back, I think your presentation really adds to Professor Finkelstein's likewise. So yes, we do need guidelines, we do need a structure of small boxes, but likewise, this was a nice slide before, the life expectancy of a female is different to a male, so you cannot just put a limit and say 70, 65. You always have to look forward, and yes, ideally, if you have a valve that lasts for 20 years, the resilience starts showing some results like this. You're probably more accustomed to the data, but and country to country is different. I'm very sorry, but in the US, the life expectancy is slightly lower.
Yeah, the worst life expectancy. We're behind China.
So the same applies to Israel and Greece and Japan or Costa Rica. So really, we have to be very specific about each patient. And I think what you're actually saying is we don't need just to have a structured baseline discussion like 75. Euroscore is okay, TAVI, or okay, surgery. We need to go into the detail. Small annulus is an important thing, but just to return the comment, surgeons are getting better because you are giving us more information. The old style surgery, when I started in the UK, my training was aortic stenosis, go and do a valve. That's not good enough. We need to know what annulus is there. The information you get from the detailed angiogram, really, we should have to, because yes, we can do an annular enlargement, which is absolutely necessary in many females in Greece. And lastly, sternotomy is not in the cards for most cardiac surgeons. This is an unfair comparison if we go back into the style of comparing and competing, because and most of the trials I think are a little bit unfair to surgery because you are real experts like Yannis is with loads of cases, great advancement in your experience, and you just pick a unit that does 20 SAVRs a year. This is not our world. In Onassis, we have done like 500 SAVRs in the last 3 years, so we do more than 160. We have stopped doing stenotomy 4 or 5 years ago. So really, this is the new era of, if you wish, comparison to see the results of minimal invasive aortic valve surgery, and there are valves that are have been used in the previous trials We have used them too. We didn't like them, but now, like you guys are getting better and better valves, we have better and better valves too. Annulus is a newer valve. It shows a very good effective orifice area. Resilia shows impressive results on the in vitro studies of long-term durability. We have stentless valves that give us a very good effective orifice. So in a 75-year-old lady, the counter argument is I can do an endoscopic Perceval placement. So if we give her 15 years with a valve like this, then we need to rethink how we choose per specific patients. Thank you.
No, I mean, I love that because because it literally is a team approach, and it is a patient-by-patient basis. I really believe that the root enlargement surgery has to be better proliferated across the surgeons. I was at the STS meeting and the AATS meeting, and all of them were very upset about the fact that we showed more PPM in surgical valves and all of these questions that you say, oh, and I just said, okay, STS, tell me how many root enlargement surgeries for small annulus did you perform in the small annulus patients? It's less than 5%. So the surgeons don't want to go under and they're not qualified, frankly. Because if you're only doing 1 or 2 of these a year or every other year, it's only 4%, you do the math. It's going to be people who haven't done it in 5 years. That's not good. So surgeons need to do more of that. And with the team, when we're talking about the lifetime management of a young woman with aortic stenosis in a small annulus, that could be me, I want to have my first operation, frankly, to be a surgical one with a root enlargement without a sternotomy in a qualified hands of a surgeon who's able to do that without complications. Because then I don't really want a TAV in TAV. How much room is in there for a TAV in TAV if you're putting in a 26 evolute valve? And this next one is what? I mean, it just doesn't work very well. So we have to do better. So the surgeons have to really, really upgrade their training programs and making sure that there's more of that. There's got to be more communication. And it is harder. It takes longer. It's a lot easier for the surgeon to go in and just watch a TAVR and get half of the RVU and do 7 of them compared to 1. I mean, let's understand a lot of this is unfortunately financially incentivized. And so we need to change this culture if we really want to treat patients well. And I think that's what we heard from Ari, and I think that's how we need to really proliferate this kind of talk. It's hard talk, like on BBC. It's hard talk, but we need to do it, and we need to be head on in thinking about this so the patients don't run around looking for who's going to do it. Everybody could do a TAVR, anybody. It's easy. A lot easier. It's simple. We're watching 10-minute procedures here. It can happen. What we need are really good decisions for our patients. So I fully agree with you, and thank you for that question.
Okay. Can you say after the SMART trial that TAVR in small annulus is a matter of device selection? Is it the last word?
I would say that at the moment, based on what we have between these 2 valve, now the Resilia is not in there, between these 2 valve, supraannular versus a balloon expandable valve, you will have better hemodynamics through 1 year. Actually, you get it by 30 days, but through 1 year with the self-expanding valve. And if all things being equal, if everything is the same, I'd want the better hemodynamic. That's what I would want. Now, if in 2 years or 3 years and these curves begin to separate, I think it's a clear-cut choice that you should go with, with a self-expanding valve.
Okay. Thank you very much.
I think there's a question.
Very quick point, 10 seconds, because I know 10 seconds. So first, congratulations on the SMART trial. I think the results it gave us were outstanding. I think they are results that we all expected to see, but until you do the trial, you can't be sure. I think that's fantastic, and I thank you as a cardiology community for making us better as surgeons. I think that these days, when you have a lady especially a lady who is short and overweight. That's the classic combination.
That's the PPM.
They walk in my door and I know that this is a candidate for a root enlargement. I think that the cardiology community needs to demand a root enlargement. Just like when you have a degenerative P2 prolapse, you demand a mitral repair, not replacement. Just like when you have 3-vessel disease,
100%.
you demand arterial grafts. You need to demand it of us. And if the cardiac surgeon you're referring to is not willing to do it, then you need to refer it to somebody else. So the cardiology community is going to shape what the cardiac surgeons are doing, and we thank you for making us better.
Thank you. Thank you so much.
Thank you.